Alright, so I'm going to be placing a lumbar epidural today for my patient who's in labor. So before I go into the room, I already confirmed that she didn't outright refuse. This would be an absolute contraindication to doing it. She actually requested to have this epidural. And I also looked through her chart just to make sure she didn't have any uncorrected coagulopathies, she didn't have an infection at the site, or anything else that would preclude her from having this procedure. So, discussing with her in the room, I first ask, can I ask your name and date of birth? Alright, and the plan today is to put in an epidural to relieve that labor pain. Alright, perfect. So I have successfully identified her. Alright, so first I just want to discuss some of the benefits and risks to having this epidural. So obviously the benefit is it would relieve that pain with childbirth, and it would also relieve it but still allow you to be interactive and participate in the birthing process. There are some risks. For one, anytime I puncture the skin, there's a risk of an infection. Two, when inserting that needle, if I inadvertently go a little too deep, it can puncture what's called a dural membrane, and if it leaves a little hole, that can result in a headache. It's called a post-dural puncture headache. There are treatments for it, but it is a pretty painful headache if it does occur. Also, if the catheter were to be threaded through that hole, if it did go through that membrane, and you were to get a full dose of medication, it could cause what's called a high or total spinal, so you'd be numb much higher than we would like, and there are risks associated with that. However, I do give you a little test dose before I connect you to anything or give you that full dose, and that would help identify that. There is also a small possibility of permanent nerve injury. It's about less than 1 in 10,000, but it is a risk nonetheless. So alternatively, we could just go without the epidural since this is technically an elective procedure. So what are your thoughts? Do you have any questions? Alright, so I'd obtain informed consent from her. And at this point, I get her positioned. I could have her put her feet up on a chair, kind of lean over a second chair with a couple of pillows. I'm going to have you arch your lower back as much as you can. I know it's not easy. And kind of stick out the lower part of your back. So I go just along the top of her hips here, along 2 fingers line. I'm just going to touch your back. And I just start like so, up and down her spine. So this line is somewhere between L2 and L4. So that's kind of my goal range. And I'm just going to identify a good spot. Alright, that's perfect. So I can mark this with a CAD key or with a surgical marker. Alright, you can relax if you need. At this point, I'm going to go ahead. I already set out my sterile gloves. I've got my kit. I've got hat, mask. And go ahead and get this stuff set up. And I have to make sure that we have a blood pressure cuff on. We have a pulse ox. And I can see her heart rate. So I'll go ahead and get on my sterile gloves. First thing I'll do is get her nice and clean with betadine, or iodine is what is in this kit. So I'll go ahead and open this, and I can dump it into this tray. Alright, so I'm going to get you cleaned up just around that site where I'm going to go in. This might be a little bit cold. So I'll start right in the center of that mark and start cleaning in concentric circles out. And make sure I get nice and around. Another cold swab. Go ahead and clear that out of the way. So I'm going to let that dry. And next I'll go ahead and pull up my stuff for my skin wheel. So I have some 1% lidocaine in here, and that's what I'll go ahead and numb her up with. So I'd use a filtered blunt needle, since it is in glass, break that and draw up about 3 mLs. I probably won't need that much. I can discard of that, and then I'll administer it with a 25 gauge needle here. So at this point, that's the only thing I have drawn up, so I'll just set it right there. And now that she's nice and dry, all right, I'm just gonna put a little plastic drape on you. Just gonna drape this up along your shoulder here. And again, if she had moved out of that arched back position, I'd reposition her back into it. All right, so I'm gonna go ahead. Again, I can still see my nice mark here. Just repalpate that spot. I'll go ahead in with the skin wheel. You're gonna feel a little stick and a burn, and then it'll get numb, okay? So 1, 2, and 3. So I'd aspirate a little bit before I injected, create a nice little skin wheel there, and then I can just use it kind of like a finder needle, just advancing a little bit, aspirate, inject a little bit, wait for a moment, insert a little bit farther, aspirate to make sure not too deep, and inject a little bit. So I've met some resistance here, indicating I'm probably next to those ligaments. I'll go ahead and set this to the side. All right, so now I'll grab my 2E needle. There we go. And make sure I've got a little stylet in it. So I'm gonna draw this out, spine your needle out, and insert it right in at the same angle, since that seems to be a good spot. You might feel a little bit of pressure. Let me know if you feel any pain though, okay? You shouldn't. So I'm gonna advance that a little bit. So I'm about 3 centimeters in there, and I'm getting a little bit of resistance, so I'm gonna go ahead, take this stylet out, and I'm going to drop, I have some sterile saline here. So I go ahead, get a filter needle, break this, drop. I go with a full 5 mLs, and then take it off. So had she not been compliant, I wouldn't have let go of the needle, but she's holding still and understands. All right, so using a Bromage grip, I'm just gonna advance this needle a little bit while applying pressure, just with this, until I get loss of resistance. Perfect. Indicating I'm in the epidural space. So I can disconnect this, and I'm gonna watch to make sure I don't have a flow of CSF. That would indicate that I'd gone too deep and was in the interthecal space. All right, so at this point, oops, I don't want that little guy. Have you hold real still. I'm gonna go ahead and connect my little feeder, and go ahead and feed my wire in. So when, let's see, this is a 9 centimeter needle, so that's 9, 8, 7, 6. So I was about 5 centimeters in when I lost resistance, and I want to make sure that my catheter is at least another 5 beyond that into the epidural space, and then you add another 6 to 7 for the needle outside of the skin. So I want to advance it to about 15 centimeters to make sure that it's deep enough in the epidural space. So at this point, I'm right about 15. So I'll go ahead and take the wire out. All right, set that over. All right, so I'll advance it like a little bit of forward pressure, not to necessarily advance the catheter, while I back that needle out. Careful. Back it out a little more. All right. And then just looking and making sure that I am still at least at 10 at the skin. So once that's done, I'll go ahead and just connect this so that I can give a test dose. And ahead and clamp it down, and I can keep it capped at this point. So my area down here is still sterile, and I have a good bit of table. So I'm gonna go ahead and draw up my test dose. So what I have in this kit is 1.5% lidocaine and 1 in 200,000 of epi. So when I draw up 3 mLs of that, it should be, and actually, where's my smaller? I'll go ahead and use a smaller one. I go ahead and draw up 3 mLs. So that would contain 45 milligrams of lidocaine and 15 micrograms of epi. So I can discard that. So again, I do that with a filter needle and bring it over here. So what I'd be looking for when I give this test dose is an increase, so a positive test dose would be an increase in heart rate or blood pressure greater than 20%, and that would indicate that the epinephrine had gone intravascular. An indication that the lidocaine was intravascular would be dizziness, circumoral numbness, metallic taste, or just drowsiness in general. Let's see. If it was intrathecal, she could have a sudden loss of discomfort, indicating it was a spinal, or she might have a warm feeling like she kind of peed herself. So again, I'll explain that to her as I give it to her. And again, I've got the pulse ox, blood pressure cuff, and I can see her heart rate and making sure it's audible so I can listen. I'd also not want to give this during a contraction because that could falsely elevate her heart rate and blood pressure. All right, so I'm going to give you this test dose. Again, let me know if you have any dizziness and metallic taste in your mouth, if you feel like your heart's racing, if you feel like, strangely enough, if you feel warm, kind of like you'd peed yourself, or if you have any other odd symptoms, just let me know, okay? So I go ahead and administer that after it's in, and I aspirate first and then administer just to ensure that I didn't have any blood or CSF, which theoretically I should be able to draw back through this catheter. So then I'd administer the 3 mLs and watch for symptoms, recycle of blood pressure as well. So we'll give that about 30 seconds or so. I should have symptoms in that time. All right. How are you feeling there? Sounds like she's doing great. So enough time has elapsed, and it was a negative test dose. So now I know I'm good to go ahead and secure it. So I'm just gonna put a little sticky on your back here. So I go ahead and adhere that. Obviously, on a real patient, I would put a full tegaderm over this and a full tape up over her shoulder. But for these purposes, I'm just going to just drape it. But again, in reality, it would be fully taped and coming right over her shoulder. So I could go ahead and move all of this out the way. All right, so next I give her her first bolus dose. So I'm gonna start with bupivacaine, it'd be 0.25%, and I'll give her 8 mLs of that. Mixed into it will be 2 mLs of fentanyl, which is 100 mics, so she get a total of 10 mLs. So I can have that drawn up over here. I wanna give that over about 15 to 20 minutes in 5 increments, like every 5 minutes or so. So I'd aspirate, administer a little bit, and watch how she tolerates it. Meanwhile, I could be charting, again, what I'm documenting is at what point I had loss of resistance with that needle, at where the catheter is at the skin, and I'd be reassessing blood pressure, pain, all of that as I administer this just over that 15 to 20 minute span. So then after that was all completed and everything looked good, I could go ahead and hook her up to her maintenance pump. So I'd start her out with ropivacaine, and it would be 0.125% and 8 mLs an hour. Mixed into that would be fentanyl, it would be 3 mics per ml. So again, she'd get a continuous rate of 8 mLs an hour, and she could have a bolus dose of another 8 ml. So the lockout would be 16 mLs in an hour. And again, make sure everything's documented, everything's going well with her, and we would be done.